Great. Good morning, everyone. Welcome to this second webinar. I'll just put my video on as well so that everyone can see me. I think we will have more people join as we start. But we've got Paul and Sandi, our other speakers online as well. And I'll just keep looking for David. So welcome everyone to this second seminar, QCGC seminar. It's a pleasure for me to welcome you all this morning. We're really thrilled to host this seminar for you. My name is Monika Janda and I'm a researcher at the University of Queensland. And my co-host today is Andreas Obermair, and he leads the QCGC research. And so I'll hand over to Lisa for now, who will have a question and answer session with Dicey Scroggins. So Dicey, of course, is a consumer representative and ovarian cancer survivor living in the US in Washington, DC. And she is deeply involved in everything to do with, raising the cause of people who have gynecological cancer. And some of you might have met Dicey because she was a attendee and speaker at last year's QCGC Patient Symposium, and just was absolutely fantastic. So we thought we'll bring Dicey along again and ask her how she's going. So I'll hand over to Lisa now for that question and answer.
Thanks, Monika. Dicey, it is lovely to see you again. Welcome back to Australia, even if it is online.
Thank you. My pleasure.
Dicey, the United States, we are hearing and seeing a lot about what's happening in your end of the world, particularly with what's happening in New York. I guess just to give us a sense of how COVID-19 has impacted you and your community, perhaps you could just give us an overview of the incidents that you're dealing with at the moment.
Sure. I live in Washington, D.C., which, as you know, is the capital city of the U.S. It's not a state. However, we have over 700,000 residents, about 711,000 residents. Yesterday I checked, and I think there were 2,927 or so, almost 3,000 confirmed cases. However, there were 105 deaths reported. So we're not a large city. We're a medium-sized city, but we certainly are being impacted by the virus. And we're finding some things that are very interesting, though. About 50% of those who have been confirmed are women. And in most cases, that's not the, most places that's not the case. It's about 50-50. The other thing that's very interesting is that a younger demographic, a younger group tends to be diagnosed. In Washington, the bulk are between 19 and 60 years old, but the vast majority are between 31 and 40. So they're fairly young.
Yeah, it was interesting when the virus hit here in Australia, we were being told that it was going to be predominantly worse in the older you were, but we're finding exactly the same, that there are
finding that at all, which is very interesting.
Yeah.
Very interesting.
So in terms of your local community in Washington, D.C., what is the community doing to, I guess, stop the spread of the virus?
We have a hashtag that the mayor came up with, or someone in the mayor's office came up with is Stay Home DC. So basically we're having people stay home. And because of that, there's just lots of interaction online, on Facebook, on FaceTime, large gatherings. People are having community get-togethers online. In Washington, we have a system of commissions that allow the citizens to get together and make certain decisions in their own area. And they're called advisory neighborhood commissions. And so the advisory neighborhood commissions are getting together online. So as much as possible, we're still having things, we're doing things together apart.
Do you find that, I guess the older generation may not be as, regular users of things like Zoom and those sorts of things? Is there a sense that the community is really trying to engage and encourage people who may not necessarily have embraced online communities?
I think that's happening a lot. There are people who I know would never have been, older people who would never have been online, don't have Facebook except to see their grandkids periodically. They have a connection and so on, but they're now getting on sort of meetups with people. They, as a family, we tend to periodically just have these family get-together. My mother's always on there, and she's someone who would never use, she doesn't use Facebook. She doesn't do FaceTime, but she FaceTimes with her grandkids. But other than that, doesn't do that. So I think the community at large, and I think this is true all over the place, probably in the US, and I'm sure other places as well, we're trying to engage people and let them know that this is a place that they can all get together. Because one of the things that people are really missing is just that human touch, that ability to see another person other than the 5 people you love most in the world you see every day, all day for, you know, months at end. So I think people are engaging who weren't before, but I think it's with the encouragement of community leaders, of their healthcare teams, and that sort of thing. I don't think they're doing it on their own. I think, though, there are certainly probably lots of people who are in their solitude and not getting that kind of encouragement and stimulation.
Yeah. So I guess, I mean, in terms of communication, we all know that communication is critical in times like this of a crisis, but also no matter whether it's a personal, family, community crisis. What are the types of communication that you're receiving as far as COVID-19 and what's happening within your community, but also around the US and the world?
I think there's actually almost a deluge of, I'm almost overwhelmed by the amount of material that I get that's related to COVID. Whenever I'm online, I always get a notice if something else comes in, and I never am on a call or doing anything online where I don't get 1 or 2 communications indicating there's a webinar of some kind or there's new information at various sites and so on. But I know that I am often online and connected anyway. I think more to the point is, how do you communicate with people who aren't already online and aren't already plugged in? And I know in the district, for instance, people are actively engaged in terms of, again, that ANC, the advisory commissions and so on. But they also get a lot of news through television, through our local stations, and through radio, and through gatherings that are online. I think that's where people are really getting a lot of information. And just talking with friends, I've found just personally since we've all been sort of staying at home, and as in DC, they say stay home DC, that I've been talking more with people that I am connected with, but I wouldn't have talked with as often. And I am talking to people who I just want to check in with them. So people are checking in. I think people are doing a lot of personal checking in, but I think people are getting their information relative to hand washing and relative to the, social distancing or spacing and so on, distancing. I think they're getting that more from their trusted stations that they tend to watch, and the people that in the community that they already trust. I think they're getting it from trusted sources, and when they haven't gotten it from trusted sources, they've gotten misinformation.
Yeah. What about things like, I guess, unexpected behaviour, perhaps? I know here in Australia, we were totally blown away by the panic buying, particularly in the early days of toilet paper. How did you experience that in Washington, DC?
No, the toilet paper issue was the first one that when I knew something was off. Was out about a month and a half ago, just shopping in a store, just getting some staples. Toilet paper, all the shelves were empty. And this was a huge store. It's a Target store. I don't know if they have them in Australia, but it's this rows and rows of paper. There's nothing there. And so my daughter and I went together, and I thought, is this because of the COVID? And it was. We have now since had to order certain things to be shipped to us because we can't find them in the store. And it's mostly paper goods, paper towels, those kinds of things. In terms of food, it's very interesting. We have started ordering food, which everyone can't do. All communities don't have a services that they can order. We're very fortunate in being able to do that. But what we're finding, and we were laughing the other day, is that once we order the food, we have a process. It sits on the porch for a certain length of time, then it goes to the garage, and we do other things to be safe. But we are fortunate enough to be able to do that. And we are finding that we are paying as much, we're spending almost as much on tipping the people who bring the food as we do on food. Because I think it's really important. We talk about the people who are the real sort of soldiers in this, and the people who are doing so much for all of us. And we think about the medical profession, think of all of those people who are making sure that we have food available and are bringing the food to us and so on. So I'm very much concerned for that. And I know it's a privilege to be able to not have to go out always to get those goods and so on. So there are places where, depending on the neighborhood you live in and depending on, the particular grocery store that you tend to shop at, some stores are always stocked and some are not. And in the US, and I'm sure in other places as well, there are food deserts. There are places where even in the best of times, there are not a lot of stores and so on, and there are not a lot of opportunities for fresh food, fresh vegetables and produce. And so that's even worsened at this point. There are people who don't have a neighborhood store and they don't have a delivery service. And I really worry for them, and children particularly.
Yeah.
Lisa, before you ask the question, I wasn't a very good host, so I didn't mention that at the bottom of the screen, if people scroll down, there's a question and answer button, and so you can click on that and you can type your questions. So for example, if you have questions to Dicey or any of the subsequent speakers, just click there and we will watch it so that we can see and answer your questions. Now, sorry Lisa, sorry Dicey.
Thank you.
No, sorry, I was talking too long.
Dicey, we've talked about older people being a vulnerable group affected by COVID-19. Obviously, women undergoing gynecological cancer treatment are also a very vulnerable group. What have you seen in terms of Washington, D.C. as the day-to-day impact of the virus on women undergoing treatment?
People in Washington are making the same kinds of decisions that women all over the world are having to make, very difficult decisions that I hope they're all making with their healthcare team, but deciding whether they're going to continue with care, whether they're going to postpone it, whether they're going to, have an adjustment in the kind of care that they get and so on. And so I'll just go to 2 or 3 just personal cases that I know of. I know someone who has to continue with her chemo. She doesn't have a choice at this point. It's not an option for her. She needs to do so. So when she goes in to get her chemo, there's a different standard than before, and there are different precautions. Everyone who comes into the center, to the hospital, has to get their temperature taken. They get their temperature taken again before they go into the infusion suite. And in the infusion suite, which I've gone to with her before, she says it's completely different, that there's huge spacing. There used to be fairly packed, not very much spacing. Now there's more spacing and so on. There's not a lot of chatter and so on. So what people are finding is, you still in infusion suites and in those settings, women and men who are getting, women if we're talking about gynecological cancers, but women who are having chemo tend to communicate with each other. They know each other. They talk about their kids. They talk about their grandkids. They comfort each other, quite frankly. And so now the comforting has to be by a look. You're making eye contact, you're smiling, you're making a hand gesture. So we're not touching each other as much in the suites, but people are still getting it. So people women and their families are beginning to understand, or have to understand, that if the treatment is delayed, it's delayed because your team with you discussing it with them believes that you can still do well and have the delay. So people are triaged in some ways. So I think the idea, for instance, that you might have neoadjuvant therapy. There are lots of women and families who've never heard of neoadjuvant. So when you say you're having your chemo first, you're going to have the chemo first, they think that's delay and that's horrible and you're leaving this, and you have to explain to them that, lots of people get it even in the best of times. So I think we have to explain things to women. I think we have to make sure that families understand and not left thinking, oh my gosh, I'm not going to make it. They're forgetting about me. The fact is, your case is very individual. Everybody's different. All of the cases will be different. And we have to explain that to women, but we really can't simply say we're delaying your therapy. It'll start again whenever. Say why, say how, say these are the options. Tell them the 4, 3, 4, whatever the options are. And most people will go away feeling better, because remember, there's a huge emotional toll that on all of us, but certainly on anyone who is undergoing treatment of any kind.
What about quality of life and stress? Obviously, women with gynecological cancer are dealing with significant amounts of that anyway. How is this impacting?
Yeah, I think the situation is just, the impact is humongous on everyone. It's huge on everyone. But certainly if you have a life-threatening illness or a cancer of any kind, it's added stress. So the emotional toll and the toll in terms of just how you live and how your quality of life is enormous. So one of the things that I share with women, and that lots of people are sharing with each other, is that you need to take time for yourself. You need to be aware that this is a stressful time for everyone, but you have a particular kind of stress. So you need to do things like, if you've never meditated before in your life, I know women who are meditating now have never, ever meditated. You can get a cute little app on your phone, and if you, that'll tell you how to start it. And if not, just sit and think, close your eyes and think good thoughts. Find a place in your home that is yours. I know now it's more crowded because everybody's at home. Find a place for you. Make sure that you exercise. Find a friend that you talk to. So there's certain kinds of things that, we're suggesting to women who are under the stress of a cancer, as well as, this whole COVID-19 piece, and you're afraid to go in. If you have the option of telehealth, telemedicine, please, use that, practice that. I suggest that the healthcare team share with all of their patients that, in fact, if you're feeling stressed or if something is whatever, and if you don't have to come in, don't come in. You might be able to do it by telemedicine. We're doing my family is doing almost everything now by telemedicine, anyone who does not have to go in. So I think as healthcare professionals, though, we have to be reassuring to our patients. And even those patients who, for instance, have to have their chemo or their clinical trial delayed, make sure you explain why to them, and make sure that you or someone in your office keeps in contact with them. Make them know that they're not forgotten. This is a temporary situation. We continue to care about how you feel and so on. And maybe suggest that they journal or do something to keep track of the kinds of things that are going on with them.
Thanks, Dicey. I know that we've got a question, Monika.
Yes.
So just before we head to the question, Dicey, I know that you're a member of the International Gynaecological Cancer Society, and I know that there is a wealth of resources that you have available for women about COVID-19 and gynaecological cancer treatment. What we'll do is we'll put links to those pages when we post the recording of the webinar. So the information that is available to women all around the world can access those links. So Monika, if I could pass over to you now for questions.
Yes. Dicey, thank you so much for sharing. There's just one question, and unfortunately then we have to move on. So the question was in particular something that you mentioned before about the process of letting the groceries into the house. So the question was from Christine, and she wanted to know exactly what you do there and why.
Oh, sure. And for us, it really isn't excessive. It sits on the porch. We always see people when they come, because we can see when someone comes on the porch. We go out to wave at them, but we don't go out to discuss anything with them. We wave at them. And if we have not made arrangements for any kind of tip or anything like that, we have it on the porch and it's on a chair so they can we leave it there for about 3 hours, and we've never had any trouble in the neighborhood. It's on a porch. We leave it there for a certain length of time, and you can determine with your healthcare professionals in the area what's a good length of time not to touch. We then, with gloves, bring it to the garage. We put it in the garage and it stays there for another bit of time, unless it has to be refrigerated. If it does, we wipe it clean. We wipe everything that we bring into our home clean. We're not being, I don't think, excessive, but we wipe absolutely everything. We wash our hands after doing it, and we wash the doorknobs, because someone may have touched out there, because sometimes they ring the bell and those kinds. So we take those kinds of precautions, because I don't know where, and we also know that the people who are delivering to several homes. And in our home, they don't come in and we don't do any, but we don't know what they're doing elsewhere. So we just make sure that everything's clean at that point, and we leave things untouched as long as we can and still preserve them.
Fantastic. Thank you very much, Dicey. It's so great to see you. So I'll hand over to Andreas now, who will introduce our next speaker, Professor David Paterson. Thanks, Dicey.
Thank you, Dicey. Thank you, Monika. It's a great pleasure to introduce Professor David Paterson, the director at the University of Queensland Centre for Gynaecological Research. David is a consultant infectious disease physician, and in his area, rather well known and rather well cited, which is one of the benchmarks of being a successful researcher. David, are you online, and can you hear me?
Yeah, I can hear you perfectly.
Awesome.
So I'm sorry, I've been a little bit late in joining the call, and that's because I had a call with colleagues in New Orleans, and I think many people would know that New Orleans is the Mardi Gras, but unfortunately Mardi Gras did go ahead this year and has led to a really very, very substantial outbreak. Just to give people a sense, the hospital I was talking to, they had at the peak, which was about 2 weeks ago, 250 patients in their ICU with COVID-19 and another 350 in their ward. So it really was a very, very substantial outbreak. Unfortunately, African Americans were disproportionately affected, both in terms of numbers and also in terms of mortality. And I'm not sure, Dicey, whether that's been a common feature across the US.
It has.
Yeah. And I guess the fear certainly in Australia is that our Indigenous populations may also be substantially affected. So far that's not been the case, but that is really an issue here in Australia.
David, that's actually one of the things that I wanted to talk to you about. So when you kindly participated in the first webinar that we held about 4 weeks ago, and as you clearly remember, we were all in a different space together. We were basically bracing for impact. In Australia, certainly, we've been, not to say lucky, because all this is not just a product of luck. This is the product of great prevention strategies and whatnot. But basically, the impact was not as severe as it was in other countries of the world. So a lot of people in the media that I follow talk now about how and when do we relax restrictions. And I guess then you were saying about the Mardi Gras in New Orleans. Maybe my question is basically badly timed, but anyway, a lot of people ask themselves that, like, how and when are we going to pull back? And my next question then after that is, what is the new normal? But maybe we start with that.
Yeah, no, that's a super pertinent question for us. And so obviously the situation in Australia and in Queensland specifically has been now a really positive one. And I guess in my mind, the reason why we've been able to get into such a good situation is that we had very early wide access to testing. And so, for example, it's probably 5 or 6 weeks ago, it seems like a century ago, the lab at the Royal Brisbane Hospital had done 1,000 tests. And at that time, my colleagues at the CDC told me that in the whole United States, they'd only done 600 tests. And I think that is really the difference, that we've been able to identify patients who have had COVID-19. We've been able to isolate them and do appropriate contact tracing. We've also been able to identify that people coming from overseas were a substantial risk group, and therefore both restrict non-residents coming, but also have this practice of quarantine in which people go to a fancy hotel. I live very close to the Marriott Hotel in Brisbane, and at the moment they've got more than 250 rooms which are occupied by people in quarantine. And I can just tell you, just in terms of us sort of thinking, oh, when are we going to start international travel? At 4 o'clock in the morning, I hear people yelling from their prison cells. It's weird to call the Marriott Hotel a prison cell, but being in isolation and not being able to leave your room for 14 days is not the most agreeable situation to be. So I think sort of boiling that down, for the impact for Australians, international travel is going to be completely off the agenda, certainly this year, and I'd say well into next year. And there may well also be substantial impositions on interstate travel. Certainly in the near future, because one risk group now in Queensland is actually interstate travel. And so for a short period into the future, that may also be a substantial restriction. Now, short of that, I think there is going to be sort of an opening up of the situation. There's still going to be an emphasis on social distancing, but, you know, schools reopening, or even potentially restaurants reopening, but with newer social distancing rules, businesses going back to work. I think that's going to happen, but I don't think we're going to see, you know, the mass events like the Dicey. We have a Super Bowl equivalent called the State of Origin, where the footballers, you know, that they are actually assigned to a team depending on where they grew up, where they played their first football, which is quite a neat idea. But that sort of mass event, I don't think is going to be part of our immediate future.
David, I completely get what you say, and thank you very much for the clear words. We heard yesterday from the government that they want to relax some restrictions on surgery. At the moment, we need to assume that when we just look at our surgical numbers and cancer surgery numbers, we need to assume that a lot of cancer surgery and like very important surgery is not conducted at the moment. The incidence of cancer is not going to go down because of COVID. So the only logical explanation is that we're going to have people sitting in their homes having cancer and not maybe being game enough to see their doctors for a medical appointment to have it checked out. What is your expert advice to those people who sit at home, who have symptoms, and who have to make a decision whether to have their symptoms checked out or by a doctor or just stay at home?
So, you know, again, we in Australia are really lucky in that now the risk to us, you know, from a really practical point of view, the risk for people is their underlying health conditions and newly arising health conditions, more so than the novel coronavirus. That's in Australia. Now, it would be different if I was sitting in New Orleans or in Detroit, but in Brisbane or in Australia. So my strong advice is that if a person has symptoms or has worrying issues with their body, now is the time. You shouldn't be frightened of going to your doctor because of fear of catching something in the waiting room. I think now is the time to really get those symptoms and get those follow-ups addressed, because we are potentially facing a bigger risk from those other conditions now than coronavirus here in Australia.
David, one last question before I let you go. We have gynecological cancer patients on this call and on this webinar, and there is a promotional push for the flu shot for the influenza vaccination. Should gynecological cancer patients have a flu shot, or is it too risky for them?
So this is a great question. The influenza vaccine is safe in our gynecological cancer patients, and now is the time. Dicey, we're heading into our winter. Unlike you, you're heading into, you know, from spring to summer. But for us, now is the time for all of us to get influenza vaccination. And that includes people who might be on chemotherapy or recovering from surgery. We don't want people to put it off this year. We really want people to get their influenza vaccine And really in the next week to 2 weeks is the time to get that done.
David, is this even the case for women who have chemotherapy right now?
That's right. Yes, they really should be moving ahead with the influenza vaccine. Of course, they should be talking to their healthcare provider about their underlying conditions, just in case there was some reason why it shouldn't be given. But the vast majority of people should be receiving the influenza vaccine.
So I can very proudly report that I received a sticker yesterday for being a hero. I'm a declared needle phobic, and I had my influenza shot yesterday. So I still feel extremely elated and proud of myself.
Andreas, before we move on, there's one question from Diane for David. So David, the question is, I finished chemo 18 months ago, 18 weeks of carboplatin and Taxol. Would my immune system still be compromised?
So Diane, this is a great question, and I always think of chemotherapy or any sort of immunosuppressive therapy a little bit like buying something with a credit card. You know, there is still going to be some, you know, if you don't, you know, you're going to have some sort of residual that you're going to have to pay back over time. I think moving to 18 months, though, the balance on your credit card is actually going to be very, very low. In other words, sure, there might be some subtle immune defects, but by and large, you know, you've got over the worst of the hump of immunosuppression. You certainly would be someone absolutely get the flu vaccine this year, but you know your body is now recovering from that insult of the chemotherapy. You know, you've almost paid off your credit card bill in full, so be reassured.
David, thank you very much for joining us for this webinar. Greatly appreciated. Thank you very much for taking the time to be with us here today.
My pleasure. Thank you.
It is now my great pleasure to introduce Professor Paul Young. Paul, thank you very much for joining us today. I realize that you're also a very busy person these days. So by way of introduction, Paul is a virologist. So Paul knows about viruses a lot. He is not a medical doctor like David is. I understood, Paul, you are a scientist, and you did...
Correct, a real doctor, yes.
And you did your science degree in Queensland, then went overseas to London. And now you are here in Queensland, and you are a member of a small group of UQ, of a UQ team who develops the vaccine. And so it doesn't take a lot to imagine that this is now the real important, or one of the very important topics that is in a lot of people's minds. So if you wouldn't mind telling us your experience with the vaccine and sharing a little bit of experience and where we're at and why this is important and where do you see a future for the vaccine. And I would like to encourage people through the Q&A button at the bottom of your screen. Please feel free to put forward questions to Professor Paul Young.
Thanks, Andreas, and thanks for the invitation to come along. The potted history. My time in England was when I did my PhD, and that was in the late 1970s and through into the 80s. And I worked at the London School of Hygiene and Tropical Medicine. The reason for mentioning that is that I have had for the 40 years or so of my career an interest in neglected diseases, neglected viral diseases. And my main interest is indeed dengue. And so we've had a long-standing interest in developing diagnostics, antivirals and vaccine approaches to dengue infections, but also understanding the virus itself and how it causes disease. With that basic background interest and an interest in vaccines, about 10 years ago, we hit upon an idea or a strategy for locking subunit viral antigens in their conformational form. These are the proteins that appear on virion surfaces that are the main target of a protective immune response, and are the source of many vaccines. Influenza vaccine, in fact, is a vaccine that's based on driving immunity to the surface protein of influenza. So we developed an approach that allowed us to present these antigens, these proteins, in a much more efficient way, one that induced a highly potent antibody response. And it turns out this technology works for a wide range of different virus diseases, including the coronaviruses. And we'd been working on these for some time. Also, to give you a bit of a feed into why we're so engaged with this particular vaccine, the world has always reacted to these outbreaks, and there have been an increasing number of outbreaks over the last 20 or 30 years. And it's been a reactionary approach rather than a preparedness approach. And in the latest Ebola outbreak, in particular around 2014, WHO really started to examine itself and how it had responded globally to these world problems. And they viewed through a special committee, they viewed the necessity of being much better prepared for the next epidemic rather than reacting to the next epidemic. And the sort of financial arm of that, or the facilitating arm of that, was an organisation that began about 2 years ago now, and that's the Coalition for Epidemic Preparedness Innovations, or CEPI. It's funded by the Wellcome Trust, the Bill and Melinda Gates Foundation, the World Economic Forum, and a whole range of different countries, most notably Norway, who have their own future fund there, and they fund into global issues, not just local issues. And that organisation has reached out and sought out individuals and groups who have technologies, vaccine technologies that can be targeted, and also platform technologies that can be applied to what the WHO was referring to as disease X. It came up with a list of about 8 different potential viruses that might emerge as the next epidemic, and they identified a number that were ticking away and with the possibility of emerging. Ebola's there, and Lassa fever, and a number of others that we know about. But they had, for the first time, identified something they called disease X, which was essentially this unknown, a virus that may spill over from the animal population into humans and emerge as a growing epidemic. So that's what a lot of us have been working on. We got a grant from CEPI that began in 2019, and our plan was to develop 3 vaccines to respiratory syncytial virus and influenza as demonstrators, to prove that our technology was sort of matches what is out there already for those particular pathogens, and also MERS. We chose MERS, which ironically and appropriately was a coronavirus that's been spreading around recently. Our plan next year was to get CEPI to send us an unknown sequence, and we were going to stress test our platform. We were going to look at that sequence, design a vaccine, and develop enough vaccine to go into clinical trials within a 16-week period. So that was our goal. What happened, of course, is that disease X hit us a year earlier, but for real. And so SARS-CoV-2, or the disease that causes COVID-19, became our target. And within 3 weeks of us getting the sequence, we had our lead candidate vaccine, having made upwards of 250 different versions of it. We had our lead. It's gone into preclinical studies. We have shown that it raises a highly potent immune response in an animal model. We're now collaborating with a group in the Netherlands to ensure that it actually protects in another animal model from challenge by a live virus. And we're also going through toxicology studies here in Brisbane. And so with all of those preclinical studies in place, we'll be ready to go into the clinic. And the plan is to go into the first arm in late June.
Wow, that is so interesting, Paul. That's like
sorry, a bit long-winded. I apologize.
No, it's a thriller. I mean, really, it's because, you know, we all hear from the Bill and Melinda Gates Foundation, and you kind of bring it all together. So you are basically saying there is actually an underlying movement to be prepared, because, you know, I was asking myself, what's the next big thing? And so you were saying you guys develop a framework to be ready within weeks if you have to. Is that right?
That's right. What we call it the rapid response vaccine pipeline. And, you know, the whole point of the 3-year grant was to finesse that to a point where it could respond as quickly as it can. So sort of we're flying by the seat of our pants a little bit at the moment because we'd only had a year of development. But with our collaborators, things are moving very fast. People here in Brisbane probably would have heard of recent significant funding boost that our program has received. And the reason for that was we decided to dismantle the typical pipeline of vaccine production and start running a few things in parallel so that we'd have a vaccine much earlier than originally thought. I mean, vaccines take 5-10 years typically, and you know, I think the fastest vaccine previously from inception to delivery is about 5 years, and we're now talking. The world is talking about, you know, vaccines in 12 months to 18 months, which is really quite extraordinary.
So, Paul, who do you believe will be the target population for this vaccine? Who, when you say you open a trial in June, who is your primary population who you're planning to vaccinate?
Well, certainly in the phase 1 clinical trial, it's about safety. We're expanding it slightly so that we will get additional data out that tells us something about the immunogenicity of the vaccine in humans. So it's about a trial of about 100 people, and they will be healthy, naive, uninfected individuals, and between the age of 18 and 55, I think the current clinical protocol is defining. So that population is a targeted one just to test the safety. The rollout of the vaccine is another question. I mean, obviously this is a virus that's affected the entire globe. So ultimately it's a vaccine that's hopefully going to be delivered right across the world. And there will be multiple vaccines. It won't be just ours. But I think there will be a case to be made during the clinical trials, if things are looking very good, that we might start utilizing that for emergency applications. And that would be first line responders and those with comorbidities and perhaps the elderly. So I think, you know, those are the issues that we would need to address probably from about September or so.
So we have 2 questions from the audience now. So Paul, the first question is this virus spread more easily between humans than previous viruses such as SARS and MERS and others? And is that one of the reasons why this one is so aggressive and strict vigilance is necessary?
Yeah, I think it's a very good question. We're still trying to unpick that, the real basic epidemiology of this virus. But I think it's a combination of factors. Yes, it appears to be highly transmissible. So human-human transmission has happened relatively easy. We do know of certain cases of super spreaders who have been able to spread to a large number of individuals. So with a person-to-person infection rate of possibly somewhere between 2 and 5, probably around 2 to 3, then it has the real potential to expand. And we've now seen that in major outbreaks globally. But I guess the other factor that comes into play is the rather large number of mild infections that this virus causes, which was not the case for SARS and is not the case currently. MERS is still ongoing. And in both of those cases, there is a relatively high fatality rate. And so from the virus's perspective, or the population of viruses that need to be transmitted from human to human, that's a less efficient pathway than mild infected individuals who are continuing to engage. So it's a combination of a high transmissibility, but also the disease rate associated with the virus.
Thank you, Paul. And the other question was, there's talk about trying to eradicate the virus before restrictions can be lifted. Does this even sound viable?
We won't be eradicating it. What we'll be doing is controlling it. And I think David mentioned some really good strategies about how we're going to start opening up society. I think we will, for the foreseeable future, be looking at physical distancing, I prefer to call it, in the community, and also a slightly different way of conducting ourselves in a business environment. I think my personal view is that it's only really when a prophylactic vaccine comes along, or a series of vaccines where we can significantly immunise the population, we'll start to see anything remotely like eradication. There is still a potential that this virus, unlike SARS, which disappeared, there is still the potential for a virus like this, which is spread so globally and so efficiently, to become endemic in our population, and it will simply become another coronavirus that routinely infects us from year to year. So if we had a vaccine in play within the next year, we could control that capacity for the virus to keep coming back each winter.
Paul, how often, this is my last question, and then we'll let you go. How often do you think we will need to revaccinate people?
Yeah, that's a good question. It's not like coronaviruses are not like the influenza. They don't drift in terms of their antigenicity as much as influenza, which, as everyone knows, we require a vaccine each year. And I'm proudly had my vaccine as well. With coronaviruses, there's a lot of talk out there about a lot of mutations and the fact that the virus is mutating to virulency, or that it will escape vaccine pressure. That is unlikely to be the case with coronavirus. We've done an analysis of nearly 5,000 different viral genomes now, and that while there is mutation, it's an RNA virus, so random mutations happen. They're not accumulating. They're simply random. Virtually all the mutations in the spike protein that have been identified are less than 1%, much less than 1% of the total population. So it's actually quite stable. So we would expect that a vaccine we generate now will be effective for years to come.
Paul, it's been immensely interesting. Thank you very much for sharing your insights and your expertise. Greatly appreciated. Thank you for joining us.
Thank you for the invitation. I've really enjoyed the other speakers. Hearing from Dicey was really revealing. Thank you very much for your contribution, Dicey.
Thanks, Paul, and I'm glad we ended with good news there, that the virus is not unlikely to mutate. So that's at least really positive. So it's my great pleasure now to introduce to you our last speaker for this morning, and this is Professor Sandi Hayes. Sandi works at Griffith University, and she spoke to you in the last webinar about the impact that staying at home might have on your physical activity and so on. And we asked Sandi back to today give you much more practical information and really tell you, well, so if you want to exercise more, how can you go about that? And Sandi, you are still on mute, so if you could unmute maybe yourself, or I can do it.
Thanks, Monika. Yeah. I got it, but I would have started talking quite easily without, unless you told me that. All right, so I'm going to try sharing my screen. Okay, you can see my slides?
Yes.
Okay. So as Monika said, I spoke in the last webinar, and this is the final slide that I put up, and it was really I suppose the meat of the presentation. So the last one was a little bit more lighthearted. There were some funny clips, but the point of today is to really be able to give you the ingredients and the recipe in terms of what you need to do to stay active during this period. So I'm going to break this slide down throughout the rest of this presentation. Okay, well, the ingredients in the recipe in terms of what people should be doing on a week-by-week basis is really the same no matter what your starting position. So for the most part, what I'm about to say applies to someone who has never done any regular exercise through to someone who would consider themselves a regular exerciser. Okay, looking at the ingredients. The first thing that we talk about when we're talking about the ingredients of a regular exercise program is what type of exercise could you do or should you do? And exercise type really falls under two major categories. And the first one is what we call aerobic-based exercise. And this is exercise that uses large muscle groups the intent, or the major intent of this exercise, is that it will increase your heart rate and your breathing rate. So it works your cardiovascular and your cardiorespiratory system, and it includes things like going for a walk, maybe jogging if you're up to that level, doing water-based type exercises, doing an aerobics type class, and you'll note I've got someone standing in front of a television screen as a pictogram here, just to make it a bit more relevant in terms of what we can do within the home. Using ergometers like a stationary bike, and then the good old skipping rope, which is actually one of the most effective aerobic based exercises that you can do. The other major group of exercises are called resistance-based exercise, and this is exercise that really targets our musculoskeletal system, and it's looking at improving muscular strength and muscular endurance. In terms of what you can do within the home, there are a host of resistance-based exercises that you can do that require no equipment apart from your own body weight. So you use your own body weight to do these specific exercises. But from there, you can add things like, or you can increase your resistance by using things like exercise bands or hand weights. Now, you may have seen little clips of people using a whole range of different things from the cupboards in their house to substitute for hand weights. So you don't actually need to go to the sports shop and buy yourself some dumbbells. You really just need to open up your pantry cupboard and have a look at the size of the cans or the jars that you've got in the cupboard, and they would easily substitute for dumbbells, or a water bottle that you can fill with water or any other substance, and as your strength improves, you increase the amount of water that you've got in these in the water bottle. Then there's other exercises like yoga or Tai Chi, and whether we would consider them aerobic based or resistance based really depends on what system of your body do you feel like it works more. So if you go and do a yoga class whereby you've pulled up a YouTube video of a yoga class and you find that you really haven't huffed and puffed throughout that session, but you've worked your muscles, you would fit that under the resistance-based exercise column. But if you can feel like your body temperature's increased, your heart rate's increased, your breathing rate has increased, then it could actually fit under aerobic-based exercise. And it doesn't really matter, I have to say, but it's just understanding that when we talk about prescribing exercise, what we mostly are talking about is prescribing aerobic-based or resistance-based exercise. There are these things at the bottom right of the slide, stretches, where it's not loading the muscle and it's certainly not loading the heart and it's not loading your lungs. But these are important exercises for maintaining mobility, and they're particularly important to do after you do something like a resistance training exercise session. But they don't actually count in terms of when we talk about how long should you exercise for. Things that don't load your muscle or don't make your heart or your breathing rate increase, you can't count them under exercise, or you shouldn't count them. Okay, so then we move into the recipe side of things, and to do the recipe, it's really about understanding your weekly plan, and under that we'll be looking at what type of aerobic exercise you're going to do, at what intensity and for how long, and the same with resistance exercise. Which leads me to this, which was put up at the end of the last session. In terms of aerobic exercise, we all should be aiming for a minimum of 3 times a week, around about 30 minutes or more per session at moderate intensity as a minimum, but you can go up to high intensity. For resistance exercise, we're looking at doing that at about 2 to 3 times a week. You can do it more, but the thing about resistance exercise is when you do it properly, you actually need to give yourself a rest or a break between resistance exercise sessions. because resistance exercise works by actually loading your muscles and then giving it a break to recover from that load. So a break between resistance exercise sessions are important. Again, around 30 minutes per session, and we want to be working large muscle groups as a priority, but you can also work small muscle groups. And I'll keep talking a bit more about this as we go along. One of the key things that I think people need to recognize is the relationship between the duration of our exercise and the intensity of exercise. So let's just talk about intensity to start with. If we're talking about exercise that's done at low intensity, this is the kind of exercise, and it could be aerobic or resistance exercise at the moment, but low intensity exercise is the kind of exercise you can do for quite a while. I've said 30 minutes, but we're really talking about, this is stuff that you could do for 60 minutes or more. Moderate intensity exercise is that type of intensity where you know you're working, your heart and your breathing rate's increased, your body temperature's up, but you could probably talk but not sing. So you could still carry on a bit of a conversation with someone if you were exercising with someone else. Moderate to high intensity is the kind of intensity that you would think about that you would be doing if you were walking to the bus stop and you thought you were going to miss it if you didn't hurry. So this is the kind of exercise that you are definitely huffing and puffing. You can still talk, but it's nowhere near as easy as the moderate intensity. So you are a bit breathless while you're talking. Moving to high intensity exercise, which is the stuff that we all know when we're huffing and puffing, when we're doing high intensity exercise. And it's at a level that really, if you could exercise at that intensity for longer than 10 minutes, it's probably moderate to high intensity rather than high intensity exercise. So if you're time poor, one of the most efficient ways of getting your exercise, of ticking kind of the box of doing enough exercise, is that you would do high intensity exercise. If you've got plenty of time on your hands and you much prefer doing exercise at low intensity, then I would encourage you to do it, but you've got to increase the duration. So 30 minutes of exercise at low intensity is nowhere near as beneficial for you as 20 to 30 minutes at high intensity. If you're working at low intensity, you've got to up your duration. Okay, so what we thought that you might find useful is if I gave a recipe for someone who would be considered maybe an irregular exercise. Sometimes you might do some planned exercise, sometimes you may not. So this is just giving an example of what someone's recipe could look like. For this particular person, we've got walking on 4 days a week, and I've used walking because by far walking is the most common form of aerobic exercise that people do and actually want to do. So it's a high preference aerobic based exercise. For this particular week, 4 sessions of walking. Mondays and Fridays is at 20 minutes at moderate to high intensities. Wednesdays at 30 minutes at moderate intensity exercise. And then on the Saturday, we're going to go for a nice long 60-minute walk at moderate intensity on average, knowing that if you walk up a hill, you'll probably hit a moderate to high intensity, but if you're walking down the hill or on a flat for an extended period, it might be more low to moderate. And then on Tuesdays and Thursdays, we've got our resistance-based exercise. If we break this up to a little bit more detail though, so that's all well and good, but let's just talk about what this first Monday 20-minute walk might look like. And you might actually plan to not leave your street so that you're going up and down just the street that your house is on, and you're going to concentrate on intensity whereby you work or you'll walk for 30 seconds towards a high intensity, so you're really concentrating on your walking pace, and then for the next 30 seconds you're going to drop back to a moderate intensity. And you can see just by doing that, one, it gives you definitely something to work on, and that 20 minutes will fly by, maybe. All right, on the Wednesday, the 30 minutes of walking, you might decide that I'm just going to go for a nice moderate paced walk. I'm going to put music in my ears and off I'm going to go. Friday though might be your 20 minutes spent in your house. You don't actually leave. It's 1 minute walk on the spot where you're concentrating on high knees and 1 minute up and down sets of stairs, for example. And then the Saturday's the nice 60-minute long moderate intensity paced walk. Okay, what about the resistance training component? What I'm showing here are some exercises, 8 exercises to be specific, for someone who I would consider more as a beginner, not used to doing resistance-based exercise program. And the first thing that we've got is, well, what's the number of resistance-based exercises that we're going to do as part of my resistance-based session? And we've got 8 exercises here. The majority, but not all, are working large muscle groups. Sorry, I'm not sure why it keeps flicking. The first exercise is an exercise that we call the sit to stand, where you've got a chair sitting behind you and you're literally just going to sit and stand up multiple times. The next one is using a wall, and it's a push-up, a wall push-up. The next one is what we call a lunge, where you're stepping forward and coming back, but with chair support. This one's called a bent over fly, where you're bringing your arms together in front of you and then pulling your arms out to the side and squeezing your shoulder blades back. We've got a calf raise, which is just standing on your tippy toes and back. This is the exercise where we're looking at a small muscle group. So you want to minimize these, but it's okay to use. And this is called a bicep curl. The 7th exercise is what we call a core muscle strength exercise. And this woman is just lying on the floor, knees bent, feet flat. And she's moving between having an arch in between her back. So for figure A, if you could put your hands underneath the arch of her back. Figure B, she flattens her back to the floor, so squishes. If her hands were underneath her back, she'd be squishing her back into the ground and then releasing and repeating. And the last one is just a shoulder press exercise. Okay, with these exercises, we'd be recommending that for each exercise, it gets done 3 sets, anywhere between 8 to 20 reps. And all together, when you throw some breaks between the exercises and the sets, this will equate to about 20 to 30 minutes of resistance-based exercise. Now, if you've never done this before, you would start at 1 set of maybe 10 reps and see how you feel. And if you don't feel like your muscles got loaded, you'd go 2 sets at maybe 10 reps for the next session. And again, if that doesn't really elicit any kind of muscle response, you feel like that was really easy, you'd move to 3 sets, for example, at 10 reps. So you can play around with the number of sets and the reps based on how you're feeling and the intensity of that session. Now, for each one of these exercises, I can modify them depending on whether someone's at a more basic level, beginner level, through to an advanced. So, for example, the sit to chair exercise, that might be appropriate, for example, for my mum, but for me, it would be more inclined, I'd be a squat, or just a standard squat exercise would be more appropriate for me, and then I can modify the number of sets and the reps. Someone who's more advanced than me would be moving to a squat jump scenario where we're really loading the muscle and then we're jumping, and on the land we'd be loading both the muscle and the bone. Same kind of scenario with the push-ups. Wall push-ups are the easier on the body. Then you can move to a modified version of a push-up on the floor, and then to the most advanced exercise. So you can see that resistance-based exercises can be modified within using the sets and the reps, but the actual exercise can also be modified to accommodate where people are at. Okay, so that's all well and good. You know, that's, if you like, the ingredients and the recipe. Here you go, I could print something out and hand it to you. But the reality is, if you're going to become a regular exercise or stay a regular exerciser, there's a number of things that really you ultimately have to do. The first of which is understanding your baseline. And what I mean by this is that you've got to actually think about, why are you even considering being a regular exercise? Why would you bother to do this when it's so much more pleasant to sit and have a cup of coffee? Think about the reason why you want to do it and use that to motivate you to keep you on your plan. The second step is to understand your baseline in terms of your treatment-related symptoms. You should have a very clear understanding of what your symptoms are like within a day and across a week, because I can tell you that if you start doing regular exercise and your symptoms start to change, the first thing you're going to blame it on is your exercise. Now, that's fine if it's appropriate, but you're only going to really understand that if you've got a good understanding of your baseline and that you can check in to determine whether your symptoms really are changing or whether this is what you would ordinarily experience in a week-to-week basis and exercise is just being something that's thrown into the mix. Understand your current exercise habits because they form your baseline from which you can then build on. Think about your exercise preferences because if you do something you enjoy, you'll be more likely to keep doing it. And be ready to think about the things that would stop you from doing regular exercise and to work out ways to get more clever at preventing barriers and overcoming barriers if they present. And then we need to define what success looks like, and you need to ensure that success is easy, particularly in the early weeks, and I'll talk a bit more about that in a tick. Okay, so understand your baseline, and then the next step is set a goal. And I'm sorry, but it doesn't get much more interesting than the need to set what we call SMART goals. And I'm sure this isn't the first time people have heard about SMART goals. So we're talking about short-term, medium and long-term exercise-related goals that are specific, measurable, achievable, relevant and time-orientated. So in the short term, I would say work out your ingredients, write your recipe and and that becomes your short-term goal. But in the medium term, it might become a little bit more broad. So you might decide that, you know, one of your medium-term goals is that in the next few months, you want to ensure that COVID-19 doesn't increase your body weight. And that would be something that you can easily measure within the home. Or you might decide that actually within the next 3 months, I want to be able to go on a 30-minute walk at a huff and puff pace continuously, whereby you're not having to kind of concentrate on working hard and then allow yourself to reduce your intensity. You know you can walk at a huff and puff pace for 30 minutes continuously. Your long-term goal might be to, you know, at the end of COVID-19, you want to be a regular exercise that you know that you're going to do exercise on at least 5 days per week for the majority of your weeks. So they're just examples, but you can modify those to whatever way suits you. Okay, plan and record, and this is really important. So I just said you need to, the short-term goals is about identifying your ingredients and writing your recipe. And then you need to record from there. Record any changes in symptoms that you've experienced as you're seeing out this recipe, because those changes in symptoms will guide your exercise progression. Meaning if you haven't got a worsening in your symptoms, you know that you can stick with that recipe for the short term or you can build on it. If your symptoms have gotten a little bit worse, then you want to back off on your exercise program. Don't do anything, just change, modify things, whether it's about the duration or the intensity. As I said before, it's important to have success early. You really want to be able to tick your boxes and say, yep, I did that and feel good about it. And once you've done that, then you can build on it. So you can see here an example of how I've built on this program is by adding on a Tuesday and a Thursday a yoga class, one that might go for 25 minutes and be more of moderate intensity, and one that might be considered more of a low intensity yoga class that might have some meditation thrown in alongside it. This is my last slide, and it's really to highlight one, expect exercise, regular exercise, not necessarily to be easy. I've been a regular exerciser for years, but I can tell you, I still don't find it easy. I have to plan, I have to know what I'm doing and when, or otherwise it's too easy not to do it. Just to give you an example of the links that someone like me will go to ensure I exercise, as it gets into the middle of winter and it gets dark of a morning, I know if I don't exercise of a morning, it doesn't get done. to make myself get out of bed, I have been known to get dressed and sleep in my exercise gear, so that when I wake up of a morning, there is absolutely no excuse but for me to get up, get out of the door. And once I get out, it's fine. But it really is just to say, exercise is not is only easy for, I think, a rare group of people. For the rest of us, it's something that we have to work on all our lives. Prepare for and respond to your barriers and make it easy. Don't ignore. The final thing I want to say is, no matter what you do in terms of your exercise, you really need to be conscious that COVID-19 has stripped away so much of our daily physical activity that we wouldn't think about. Whether it's the walk between parking your car at work and walking into work or not, walking to the coffee shop, going off to the grocery shop more regularly than what we might be doing, just the general movement that we would have that exists beyond the boundaries of our house. And exercise cannot fully accommodate that unless you're probably doing more like, 1.5 to 2 hours a day. And so I'm not suggesting that you do that, but I am suggesting that you really look for ways to be as active as possible in the house. I've put some, basic pictures up here to kind of highlight what I mean by that. And it might mean, if you've got time on your hand, you might go back to some basic recipes in terms of baking bread the old way. Certainly doing household chores. Instead of using your blower to remove leaves from an area, you might pull out the broom. Doing things standing up that you might ordinarily do sitting down. This picture at the bottom is about moving during commercial breaks. So every time there's a commercial break, if you're watching something on television, every time there's a commercial break, you use it as your cue to either stretch or to get up and move. So I hope that's given a few more concrete tips in terms of how you can keep moving in as many ways as possible during COVID-19, and that you actually see out COVID-19 in a more fit, stronger state than maybe what you were before COVID-19 began.
Thank you, Sandi. That was really great. Just one quick question before I pass back to Andreas. So you spoke about symptoms and recording symptoms. So how about, can exercise actually help to relieve symptoms, in your opinion, especially if you're undergoing gynecological cancer treatment currently?
Yeah. It's one of the more unexpected benefits, if you like, of being regularly active and doing planned exercises, that we know exercise can actually reduce the severity and the number of treatment-related symptoms. But one of the reasons why it's so important to record them is that a change in symptom is often perceived as being something, it's like a red flag, something's going wrong. So for example, in our lymphedema studies, we had lots of women say to us, something's amiss, and they were worried, and that they were linking it to exercise. And we actually had to remeasure their lymphedema at a time when we hadn't planned on remeasuring it. And it turned out that the women who were putting their hands up saying something's amiss were actually experiencing measurable improvements in their lymphedema. Mm-hmm. So it is important to understand your symptoms and to think about whether that change in symptom is actually potentially a better change or a worse change, or it's just something is different that's going on.
That's right, exactly. So thank you, Sandi. And people can look at your Instagram page. I can move it if they want some tips on how to exercise and so on. So
it's not really too intense. I don't bombard you. It's much more about just keeping it in the back of your mind, how important moving it is, no matter the day and no matter the circumstance.
Yeah. That's great. Thank you. So I'll pass on to Andreas to say the farewells and guide you through the QCGC website if you want to subscribe to QCGC newsletter.
Thank you, Monika. I just wanted to take the opportunity to thank Monika for sharing, and I would really like to thank the presenters, Dicey from overseas and our presenters from Australia. Thank you very much for your presentations. I really enjoyed every one of them immensely. Before I go, I just wanted to make sure that you are aware of the website of the Queensland Centre for Gynaecological Cancer, gyn.org. And if you wish to be included into our regular messaging, go to our website and scroll right to the bottom of the page. You can like us on Facebook, follow us on Twitter, or you can click on this button here, and you can put in your email address and your name, so that you receive our newsletters. On behalf of QCGC Research and on behalf of the team and the webinar team, I would like to thank everybody for joining us today. We may be seeing you for the next version of the webinar in a few weeks' time. Thank you very much.
Bye, Dicey. Bye, everyone.